So, welcome to another amazing episode of Diabetic Foot Files LIMBWatch edition, the segment where we step inside the real time decisions that determine limb preservation, functional recovery, and patient survival. This is where surgery meets strategy, where vascular wound and multidisciplinary care intersects that critical point between healing and amputation. We focus on what's happening also in the operating room as well as the clinic, as well as our concept on consult notes that decide the trajectory of a patient's limb. And on LIMBWatch today, we have the most amazing Stephanie Stellini Turner. So Stephanie Stephanie Stellini Turner is a full-time surgical physician associate at Christiana Care, which is a level 1 trauma center and a tertiary care hospital in Delaware, about midway between Philadelphia and Baltimore. She covers hospital-based patients, mainly doing perioperative care for plastic and reconstructive surgery, where patients who are referred to them for advanced reconstructive options such as microsurgery as well as a course of wound care coverage. They also offer advanced reconstruction options for patients who have surgery such as mastectomies, head and neck, colorectal, gynecological, as well. I know I pronounced that wrong, and orthopedic cases. And they also offer limb salvage for select patients. And then they also cover hand surgery services in conjunction with orthopedic section. And she has helped as a first assist in the operating room as well as cover perioperative care in ENT and urology. She does it all, honestly. Prior to the current position that she has worked in the medical ICU where she did vent management as well as bedside procedures, but her first love has always been surgery. And she has served on various patient safety committees like for catheter associated urinary tract infections as well as wound dehiscence. And she's also a member of the University of Delaware Alumni Association Board of Directors, and she also mentors the pre-physician associate students to help them get into PA school. So welcome, Stephanie. Yay!
Thank you, Gabby. You're so sweet. I feel so accomplished when you say that.
You're amazing. I remember when I first met you in Santa Fe, and you were just a wealth of knowledge and it's just so fun to talk to. I was just like,
I feel the same way about you, Gabby. And I have been listening to your podcast and wading through it, and I am amazed at how much information you are covering.
Okay, Stephanie. So, what made you first fall in love with surgery?
I think that the first time I scrubbed into the OR during my PA school rotations, I really knew that it was a special place for me. I really just lost track of time in there. And, I would look up at the clock and be like, wow, it's been a couple of hours. And I mentioned it to the surgeon that I was working with, and he said, that is how you know surgery is for you. I do think a lot of OR team folks at the table, feel the same way. You just get completely lost and focused on the process.
Oh, wow, that's incredible. I was always scared of the OR. Just, like when I first started out, I was always scared because,
It can be a scary, intimidating
yeah,
place. Yeah,
yeah.
yeah, it still is a scary, intimidating place for me after all this time. It still is, yeah.
Wow. So, did you always know you wanted to go into work in reconstructive surgery?
Well, not really. I mean, I've tried a lot of different things, as you can tell, and I've tried to kind of keep a little bit of those disciplines with me as I've gone through my career. I really initially wanted to do either trauma surgery or emergency medicine, but I really just had a different path. And I think a lot of times if you go into something saying, I think that I really want this discipline, and sometimes you pivot and decide that you really want something else. Like I know PAs that wanted to go into neurosurgery and ended up doing family medicine. And I know PAs that wanted to do internal medicine and wound up doing emergency medicine. So I pivoted, and I think a lot of people pivot as well too. So
Mm,
yeah, but I ended up in reconstructive surgery and I love it.
that's beautiful. So, what drew you away from ICU medicine and back into surgery?
Mhm. So, when I got out of school, I was thinking trauma surgery or the ICU, and the ICU position opened up. It was new. And more importantly, they accepted new graduates, and they had an amazing orientation process where the experienced PAs would pair up with us and cover common topics like sepsis and DKA. But I did it. I put in 2 years. I, enjoyed the parts of it that I enjoy, but after 2 years, I knew it wasn't for me. And a position opened up in surgery, and I made that leap. And I have been working in some form of other surgery since about 2010.
Oh, wow. Wow. Okay, definitely. Okay, so for those who don't understand what a surgical physician associate does, what does a typical day for you look like?
Well, I'm sure it looks different for someone who's practicing in the office, but I'm hospital based. So
Mhm.
on my floor days, I get in around 7. I look at my post-op patient charts. I look at things like their vital signs, if there were overnight events, what their drains were. I round on them, sometimes with the surgeon, sometimes independently. And if they are ready to leave, I'll send their discharge meds, finish up their paperwork, finish up their orders. And then I will usually start on consults, follow up visits with our post op patients or our pre op patients, and have discussion with those doctors and their attendings and any other doctors that might call and need information about those patients from me. Between all that, I usually respond to pages, messages, and before I leave, usually if we have a free flat patient in house, I will usually double check them because they require more time and more in-house effort
Mm.
than a regular runner. They require more monitoring, and usually they're in the particularly if your first few days post-op, they're either in the ICU or the step-down unit. So they do require a little bit more love and care. For OR days, I'm pretty much scrubbed all day, post-op notes, post-op orders. To be honest, I actually don't do plastics cases on my operating room days because we have dedicated folks that do them, but a lot of times we will touch base before and after, look at pictures, get an idea of what's going on, and of course, I'll communicate with the surgeons about those cases as well. So it's pretty busy. It's busy.
Yeah, wow.
Mhm.
So what's something you think people would be surprised to learn about plastics and reconstructive surgery?
I mean, I think what surprised me least about reconstructive surgery is that our surgeons are really skilled with human anatomy, like all of it. It's not, we tend to think of plastics and cosmetics as skin and soft tissue, muscle, maybe fascia. But for free flap, really, you've got to be able to evaluate like things like perforators interop, and then so tiny vascular anastomosis. We also we do mandibular reconstruction, so we've got to be able to harvest a fibula. So some of our surgeons do some nerve grafting as well. So it's not just skin and soft tissue, it's pretty much everything.
Oh, wow, that's really cool.
Yeah.
So, is there a patient story that stayed with you throughout your career?
Well, I mean, there's so many. What and I know that trying to think about something inspirational, but to be honest, the thing that stuck with me is that when I was a social worker before I became a physician associate, and while I was a social worker and I had just come back from my maternity leave and I was very, refreshed and happy and full of optimism, and I took care of a patient and I discharged this patient, and after he was discharged, I found he was a very unsavory person with some he had done some reckless actions that had resulted in a motor vehicle accident with a medical van, and there were multiple deaths. And again, he was a very unsavory person, it turns out. And I'm kind of glad I didn't know that because I would not have guessed. And I think the thing that stayed with me is that it doesn't really matter what patients do. Even however we judge them, however we feel about them, they still deserve the best care that we can give them, even if they are unsavory.
Yeah, no, I totally agree. Like, if I have to deal with somebody who's been prison or prison workers, I just never ask them what they do. I just never do because I just know myself and
Yeah,
I just, just keep it with what I came here for because
right,
I feel like I'll personalize it and take it on. So I
right.
completely understand where you're coming from. And they have episodes of that on,
Absolutely.
you know, like the pit or something like that.
Yeah. Yeah, and 'cause we took an oath to do no harm, but I think part of that is, to take it even further, the part of that is everybody deserves the best care that I can give them.
Mhm.
Mhm,
I totally agree with you.
mhm.
So, have you ever seen a limb salvage case where you thought, "Wow, this is why I do this"?
I I mean, pretty much everyone is just amazing to watch the process and watched it all the way through, so I wish I could think of one, but I keep thinking of a bunch of different ones, and I'm like, "I can't settle on one." They're really they're really good stories, and we're lucky to have pretty good outcomes with our patients.
And just on a weird side, no intended, you've done mission work as well.
Mhm.
You
Yeah,
started to
that's
mention that.
oh, yeah, yeah, I don't yeah, I mean, I like mission work. I think sometimes I try to carefully evaluate my missions, though, and make sure that, I try to think, would the money that I spend on this mission be better served by doing something locally? And that's how I evaluate it. Like one of my favorite missions were when we went to Honduras and did hips and knees because there was not a wasted moment. We worked the entire time. And hip and knee replacement is, I don't want to say it's an easy surgery. It's not an easy surgery, even in a hospital environment. In a hospital, it's not an easy surgery, but it is also something that you don't doesn't require a lot of follow up. So you
Mhm.
can do it, and they're life changing for patients. And I think that that was easily my favorite mission was Honduras.
Oh, wow. Do you
Mhm.
have an estimate of how many patients y'all saw during that
Wow.
mission?
We so my I used to know these numbers, but my team did 20 knees. There was
Oh,
another
wow.
team doing knees, and the other 2 teams did hips and one did hand surgeries, as there's a lot of machete injuries in that area. That's apparently when you are a boy and you become a man, your gift is a machete. So there's a lot of defensive wounds. So it's in 6 months, you go back and you post-op these patients, they recover with paracetamol, acetaminophen.
Yeah. Mhm.
Yeah, and some of them are jumping, skipping across the floor because they can work again, they can support their families again. They can take care of their children again, and I think that is a really worthwhile mission.
No, that sounds beautiful. I didn't know that. So,
Mhm.
what's one surgery or case that completely changed how you see medicine?
Like, is that there honestly doesn't seem to be just, like, one case, like, I have so many. I mean, I've scrubbed a couple cases recently that I was like, "Wow, I really feel like a dinosaur, like, I have done so much, and there's so much new stuff." Like, I was thinking actually when I was thinking about this, I was thinking about how we talked about vascular being king. We really need vascular to do what we do, to do what you do, and to do what I do. And I got to scrub a case recently, and I didn't know we were doing, like, balloon shockwave therapy during angioplasty.
Mm.
I'm like, that's lithotripsy's been around for what, 50 plus years in for kidney stones, and now we're putting it
Mhm.
inside vessels and getting and these surgeries are just life changing for people. I think if I had to narrow it down to one particular case, and I don't want to like give too much patient information away, so I'm going
Yeah.
to just
Mhm.
use a generic pronouns.
Yeah.
We had a 22-year-old, and they had a degloving injury of the heel that fortunately didn't include the Achilles and part of the dorsal foot, and we did a ALT free flap. That's where you harvest the muscle and fascia and basically the anterior lateral thigh with the perforators and attached it to the bottom of the foot to form a plantar surface. And we put Integra on the dorsal surface, And when we, unfortunately, because of insurance, we weren't able to follow up. But once we had gotten them to, about 3 months out, they were starting to be able to bear weight on that. They had had fractures, of course, pilon fracture, tib fib. So that's the part of limb salvage with trauma that stinks, is that you're not just dealing with the skin and soft tissue, you're often dealing with a fracture and the associated risk of osteomyelitis. But for this patient, it they were only 22. Like,
Mhm.
so rather than dealing with an amputation for the rest of their life, we gave them a fighting chance to have, 2 legs and 2 feet. And I think that's really important, particularly with any patient, but particularly with younger patients because they have the whole lives ahead of them.
No, that's actually quite beautiful because, just on a side note, I had a patient when I was working in Jersey. The patient, we see a lot of patients, especially around, what's it called? School, beginning of school time, because they need orthotics and shoes. And it was a patient, and she came with her brothers and sisters, and she was about, I think, about 10, 9, or 11. I'm not sure. But she had macrodactyly on bilateral of the hallux. And the parents told me they just wanted to know my second opinion. They wanted to amputate. They wanted to amputate her toes and both, yeah, both instead of doing debulking. And I asked them if they ever discussed a debulking procedure with them, and they said no. Yeah, and I was just surprised that nobody ever discussed that with them, and that they were literally about to amputate her two
Wow.
toes. And this is a young girl, you know what I mean? And why not give her, like you said,
Sure.
yeah, yeah.
Such an important part of the biomechanics of the foot, right?
Yeah. No, of course, like, your hallux, you have to propulse off of it, but I thought it was absolutely bizarre that their first and only option that they were given was amputation, and it wasn't that big of a macrodactyly, like, the toe was about 2 to 3 times the size. It wasn't that bad, and it definitely was something that could be debulked, but I referred them to a really great limb salvage doctor, so
Yeah.
we'll see.
We
Yeah.
we do some of the lower extremity flaps we've done, like we've done a lat flap to the foot and ankle of a patient who had another bad motor vehicle accident. And after the muscle sort of like atrophies down in a couple months, sometimes we take those patients back and trim that flap down to so that they can fit in a shoe.
Oh.
So yeah, I totally see what you're saying there.
Oh, wow, I did not know that. I did not know
Yeah, you gotta wait
that
for the muscle to atrophy. It takes a couple months because it's not innervated anymore. Still has blood
mhm.
supply, but it's not really innervated. But you gotta wait for all that atrophy to happen, and then at that point in time, because fitting in the shoe is everything, right?
Mhm. Yeah. Do y'all have, like, a orthotist on that y'all just specifically work with?
Wow, unfortunately, we have to subcontract those out, but
Oh,
it'd be nice, but no.
okay. Okay. So I have another question. What are some of the hardest wounds, in your opinion, to reconstruct?
Wow, yeah. There's a lot of really I mean, one of the main surgeries that we do is reconstruction after breast cases, and
Mhm.
it's kind of our bread and butter. And I don't think I ever realized how difficult of a case it is until I scrubbed one day. Because these are like 10 to 12-hour surgeries. They require two surgeons. One harvests like an ellipse of the abdomen with the perforators, and essentially they close that up as an abdominoplasty. So you get a little tummy tuck out of it. But the other surgeons are up top, like dissecting like the internal mammary, which is like you're very close to the great vessels, so you're basically harvesting, under the third and fourth rib, the perichondrium. And sometimes you can actually see like the great vessels like pulsating underneath of it all. And that's a scary place to be. So they're dissecting up there while the other surgeon is dissecting down at the abdomen. And then you're basically connecting those perforators together with a tiny microvascular anastomosis with loops with microsurgery and then shaping a breast, out of that basically. From, a technical from a limb standpoint, I also tried to think of it from that standpoint as well too. Anything basically involving the plantar surface, a weight-bearing surface or a non-weight bearing fracture will it literally make me cringe. it's really difficult balance to allow the flap, the skin and the soft tissue to heal, keeping that flap elevated to keep edema from damaging the flap, but keeping weight off the fracture, but also keeping them from getting foot drop. Because as
Mm.
they're laying in bed for that long period of time, they're kind of like plantar flexed, and you can't really put an AFO over a healing flap. So those are some of the things that I think of when I tend to be like, "Ooh, that's gonna be a tough case." Yeah.
I do have another question. How long does a patient have to, in your from your experience, has been non-weight bearing after the flap, if it's on the plantar aspect?
It's so again, like, a lot of times the fractures are sort of taking precedence, like,
Mm.
about a week ago, I had not a week ago, a couple months ago, we had a patient with a bunch of, like, tib-toe fractures, but also patella fracture, so that patient had to keep his knee straightened the whole time, and that made everything even worse because what we do with a patient who has a sometimes with a plantar injury, what we've done is we've actually put an external fixator for a couple weeks on as well too.
Uh-huh.
The fractures usually are more give more what's the word I'm thinking? The fractures are usually longer weight bearing period than we would allow for a then the flap needs to be non-weight
Uh-huh.
bearing. If we have a lower extremity flap, what we'll usually do is we'll place a vac or a skin graft. We'll usually place a vac over top of it. And then in 5 to 7 days, we will take the vac down. And then after that, we'll do dangle therapy, which is where you basically allow the patient to sit on the side of the bed with the limb in a dependent position for about 5 minutes, and we watch the flap and make sure that it doesn't become engorged. Then if they tolerate that, then we'll increase that to like 5 minutes twice a day, and so on and so on and so on until they'll be allowed to actually start weight bearing on it.
Oh, wow, I never heard of that, forgive me, but
Yeah,
that's really cool, jangle therapy.
yeah,
Okay.
yeah. Because they have lost, a lot of these cases they've been on bed rest for a long period of time. They've lost their vascular tone. So you can't
Mhm.
just like fill that, fill it up with blood right away. We're still watching that flap a lot of times, especially in the periop period. So it's individualized, and my surgeons basically tell me, okay, this is how we're going to do it. And if I have questions or concerns or anything like that, I get back to them and I basically say, hey, this is how it went. It didn't go well. Can we try this? So I like to think of our relationship as pretty collaborative.
Oh, no, that's
Mhm.
beautiful. So how important do you believe that timing is in between wound coverage and reconstruction?
Well, so for lower extremity fractures, the conventional wisdom used to be early coverage, like within 5 to 6 days. That's according to there's different classifications of these fractures. There's Gustillo and there's Bird classification. The 5 to 6 days came from the Bird classification research. But now it's moved towards, the wound has to be adequately debrided. It has to be clean, including the bone, especially the bone. Even if it takes multiple washouts, we can place a vac in between and then wash out again and look and see how things are. Debridement can cause, I never actually knew this, but I was looking research up, and debridement can cause like tiny, tiny like clots
Mhm.
at the ends of the blood vessel, right?
Mhm.
So then the tissue around that gets necrotic. So sometimes you have to take them back and do multiple washouts. And so I think the timing is more when it's clean and when the bone is adequately debrided. And if it's not clean, then you might as well just vac over top of it. If you've got, tendons or vessel exposed, you can place some Integra over them. You can do tissue rearrangement over the vessels. There's all sorts of things that you can do. So, we've tried to do our free flaps as soon as we can, but sometimes also too, the OR is just not cooperative because these are big surgeries and we need the microscope. And we don't want to be doing them at 9 o'clock at night, frankly. So
Mhm.
it's however long it takes is kind of however long it takes.
So what physiologically happens if a wound is left uncovered for too long?
Well, yeah, we know, these wounds get biofilms that shield all those nasty pathogens that the skin envelope would normally protect us from. So anytime the skin envelope is disruptive and we get wound biofilms, we get the risk of wound infection, we get the risk of poor wound healing. Plus, the uncovered wound is very painful as well for the patient. And that's, psychologically, that can be very discouraging. So, that's why we use a lot of backs. We never want to rush into a big reconstruction until the wound is clean and the patient is as optimized as they're going to get. Because when reconstruction fails, what you're left with now is a bigger wound and then sometimes a donor site that doesn't heal either. So we never really want to make the patient worse. I've, but again, if a patient has a loss of a lot of skin and soft tissue, it is a worrisome and dangerous situation. I had a patient get like a mold in their wound once, and
Yep.
that's and fungus as well too. Those sorts of things are bad juju, and we certainly don't want that to happen. So it's about balancing the risk of timing and rushing into a reconstruction that may fail. It's a
When
balance.
mhm.
Mhm.
When it comes to you encountering, I know it's rare for you to encounter diabetic or vascular patients. What
Oh, I've
makes
got
it
them. Yeah,
make them especially challenging surgically?
yeah. So we know that these patients, have, they're really, from a reconstructive standpoint, better off being optimized before starting into a big surgery that is going to have difficult recovery. So we'll usually use local care, a VAC. For diabetic patients, do believe you talked about this in a prior podcast, that looking at an A1C of about, under 7.5, some plastic surgeons will want 7, but we know that not every diabetic patient will get to a 7. Ideally, again, the American Society of Plastic Surgeons is kind of waffled around this 7 to 8 before an elective procedure to prevent any wound healing complications. Most flaps aren't really urgent, and some patients may never be healthy enough for flap reconstruction, but we'll try. We have to keep in mind the comorbidities of these patients. If a diabetic patient, of course, has lost protective sensation, I would counsel them to avoid heat, ice, lotions, creams, or anything like that during the post-op period as well, too, because they have lost protective sensation. And of course, peripheral artery disease, we always want them to have, vascular surgery input and be as revascularized as possible before any surgery. The other flip side thing too is that, these aren't always the healthiest of patients. They have heart issues. They're on anticoagulants, antiplatelet agents. So we also want to talk with whoever is ordering their blood thinners and to be sure that the perioperative management of these medications are important. With free flaps, we usually put these patients on a month of aspirin afterwards.
Okay.
So we don't necessarily, we just use baby aspirin, but we don't necessarily want to put them on another blood thinner without talking with their cardiologist, talking with their vascular surgeon. So these patients are challenging, but it's, if we have at my hospital what's called a CSO, a Center for Surgical Optimization,
Oh,
and
that's nice.
we send patients to the CSO before surgeries like this sometimes to not only do their clearances, but also to do this optimization and make sure nutrition is on board, to make sure that they have adequate protein stores, to make sure that if they need any surgeries or procedures beforehand, they can get those done. So we try to really communicate with all of our, multidisciplinary colleagues before we undergo a big reconstruction.
That is amazing that y'all have a center like that. It seems like y'all have every step, like y'all have a very good, well-oiled machine for reconstruction and limb salvage.
Yeah, I like to think that we do. I like to think that we do. Yeah. Yep.
Oh, wow. Okay.
Mhm.
So when it comes to mentorship, right? What
Mhm.
advice would you give students trying to get into PA school?
Okay. Well, I mean, a lot of them, at least not my students, there used to be these 5-in-1 kind of or 4-in-1 type programs where they took very young students like college and then they would do another year and then they would have their masters. And I thought these students came out a little bit green. And by green, I mean inexperienced. I really tell them that, and most of my students are not going to these programs. They are spending time outside of the academic arena, like in healthcare jobs. Like yesterday, I spoke to a pre-PA student who was working as a CNA. And I'm like, keep doing that. You're not only are you going to be, getting valuable patient contact hours and patient experience and learning to deal with difficult situations and angry patients, but you'll have some references when you get done that too. So I do tell them that to consider working in healthcare before applying to PA school. I think that when you've been out in the real world, it makes you a better practitioner, honestly. I also tell them to consider other options because PA school can be weirdly selective. There's definitely more applicants than there are slots. So I
Mm.
tell them consider medical school, consider being a dentist and consider nursing school. If I hadn't actually become a PA, I would have definitely considered becoming a CRNA, a nurse anesthetist, because I like airways because, there's that ENT in me that really, really likes airway. But that's what I would have done. But I tell them to consider this because it's another path to what you want. Doesn't necessarily just have to be, being a physician associate. There's other ways to practice healthcare.
What qualities do you believe make someone successful when it comes to surgery?
I mean, all kinds of people work in surgery. So I couldn't really think of I can't really think of a unifying feature, but focus is one since the OR sort of demands that quality of you. I also think that anybody in medicine really has to have a thick skin.
Mhm.
Um, you're gonna have your bad days in surgery. You're gonna have angry families. You're gonna have crying patients. And, what do you do when you have a bad outcome? Or what do you do if you cause an injury? How do you pick yourself up and keep moving on because you probably still have patients to see and patients to take care of?
Mhm.
So I think that you have to have some level of resiliency to be in surgery. Not that that is exclusive to surgery, but
Mm-mm.
certainly that would be that would be one of the main things that I would think of.
Like, on a side note, I was looking at
Yeah.
this article that was on the news, and it was this amazing neurosurgeon, and he saved this gentleman's life, and he gave him 4-star review.
Oh
And the
wow. He saved
yeah,
lives.
yeah, he saved his life. So I'm like, yeah, you can't keep everybody happy. The man saved his life. I think the
I would take that as a win and just walk away.
Yeah, yeah, like, you were able to make the review, like, you were actually able because he's a neurosurgeon, he saved your life, definitely, and he literally put there, "He saved my life," but 4 stars.
Oh, okay.
Yeah.
Rude, Papa Rude.
How do you avoid burnout in a high acuity environment like surgery?
Wow, I don't know. I think maybe it's because maybe it's because 'cause I'm seasoned, and by seasoned, I mean old. I think that you have to take your time off, and
Mhm,
I think you have to be able to leave it behind when you go home and you're with your family. If I as a young social worker, I really used to bring all my thoughts and big feelings, and I should have done this and I should have done that home with me, and sometimes I still do on a bad day, but you have to kinda, like, block it out of your brain and have that other compartment of your life that is, that you bring to the forefront when you walk out of the hospital or the office. I'm a big believer in always having a vacation planned, even if it's just something short, something really to look forward to. So and I try to be part of the solution. If there's a problem, then I have time. That's the other part too. I do tend to overcommit.
mhm.
If there is a problem, I try to look into what's the solution is. Has someone done this some before? Has someone done this and does someone have a better way of doing this? So I try to be part of that solution as well.
Oh, wow, and I
Yeah.
think that is absolutely phenomenal that you were a social worker, but prior to this, I think that gives you a whole different edge
Yeah.
above a
It
lot of
definitely
people.
did. Yeah, it really helps with patient care and patient contact. Like when I walk out of a patient's room, I really want them to know that, I may not have been able to do anything for them, but at least they were listened to.
Mhm. Yeah.
Mhm.
Wow.
Yeah.
Okay, so we're closing in. So what's one thing you wish patients were able to understand better when it comes to wound healing and recovery?
Um, do you ever have like patients come into your office and they're a little bit like unrealistic about how long it's going to take to heal a wound? So that's why we do a lot of preoperative planning with our patients. We just tell them it's a process. It's going to take time. We try to give them realistic time expectations about how long it's going to take to heal a wound. And that is one of the reasons why, plastic surgery always is running around with this really nice high quality camera. And we have specific ways that you take pictures. We try to take a big wide shot and then we start honing in on the wound. That way we can take these pictures and, we can show them to the patient and be like, look how far you've come. We want to document this progress because you're not going to see it day to day. For patients who are candidates for reconstruction, it's very important to have their buy-in with what that flap is going to involve because there's, especially with trauma and with diabetic feet, like, it often involves long periods where you're stuck in bed rest. This is the only place where in the hospital where we actually are saying, yes, the patient is legitimately on bed rest. They cannot shear this flap off. They are non-weight bearing. They have multiple surgeries. They have staged procedures. They have skin grafts. They have vacs. So it's really important to kind of have that buy-in with them, so that, and they also need a clean wound healing environment at home. Certainly, you've talked about the social determinants of health. What happens when you have that patient that is homeless? Are they a great candidate for reconstruction, or are they a better candidate for local wound care, or are they a better candidate to send to a skilled nursing facility for a period of time so they have that clean local environment? So, and actually, I didn't just talk about one thing, but I guess the one thing I was trying to get at there was that it's a process. We're going to support them, and it's going to take time, and to try not to get discouraged with it.
I totally agree with you. It is the patience thing. I totally get it. But yeah, yeah, sometimes they just want it to heal. They just want it over and done with.
hmm
But
hmm
yeah.
I think
Um,
one thing that you and I have both talked about too before is that and that you have tried to hammer home on your podcast is that it's easier to prevent wounds by arresting this pathology that causes them. We know that good blood sugar control, or the best blood sugar control we can get, tobacco cessation, exercise, control of hypertension, good nutrition, these things are like a seatbelt. It's so much easier to prevent these things from becoming a wound than it is to deal with a wound after it has gotten big and been ignored for a period of time. So prevention is super important.
what gives you hope about the future of reconstruction and limb salvage?
Yeah, it's wow. I don't know. I think we're in a really good place. I think we're able to do really, really, really cool things. And, I am encouraged by the fact that we have a really strong section leader and she works very hard to kind of get us the things that we need when we feel that, we're we're short of a resource. And we have some really strong dedicated PAs both in the hospital and in the office as well too, that really work hard on solving problems. Like if there isn't we had a patient who had a terrible reaction to Dermabond the other
Hmm.
day, and one of our yeah, and not only that, once you take it off, it's still, the process of taking off Dermabond obviously damages the skin in and of itself, and then once you get it off, it still takes time for that to resolve. And our one of our office PAs has met with the Dermabond reps quite a few times to try to make them aware of this issue and see what can be done with it. So we really like to hunt down problems and try to fix them as best that we can.
If someone is listening to this podcast and is struggling after a major surgery or a limb-threatening condition, what advice would you want them to hear from you?
Well, I mean, I think all patients struggle to some degree after a major surgery, maybe in the middle of the night at 3 in the morning when, someone's just woken them up to take vitals and they can't get back to sleep. I think it's really important to acknowledge that struggle because it's very valid. Part of our job is to remind patients how far they've come
Mm,
and to encourage them. And, again, we can use pictures on the camera to remind them. In my institution, we have therapists that, we can engage, and we can also engage family because they're a huge part of the process. We can't have a successful reconstruction a lot of times without a caregiver at home. And for limb salvage patients, this is something nobody wants to talk about, but if for limb salvage patients that don't have great outcomes, they can still get an amputation if they
mhm,
don't have a great outcome and they feel that they'd be more functional with a prosthesis.
mhm,
So, I mean, there isn't any magic things that you can say to them other than acknowledge
mhm,
their feelings and try to help them through it and try to help them see the positives where they maybe have those gray colored glasses on, maybe help them take them off and see things a little brighter.
mhm. That's
Mhm.
beautiful. So now we're gonna just do our rapid fire round. So yay. So so what in your opinion do you think is the most overrated and underrated treatment in wound care?
Overrated. You know, I can't think of anything off the top of my hand that's overrated. I remember listening to the guest the other day that didn't like the vacs and talked about them beeping at home, and I under 100% agree with that. If your vac is not holding a seal at home, that is awful. I think the most actually, let me say that again. I think the most overrated wound care option are those incisional vacs. I do not like them at all. I like to be able to see my wound, and I don't like when I peel one of those off and I see necrotic tissue under a wound because somebody left it on, or I see a hematoma underneath of there, and I would have been like, see, if I had just been able to see this every day. So I'm not a big fan of a incisional or a strip vac.
Oh,
Nope, not a fan, not a fan.
oh,
If you got an incision, I would really like to be able to see it.
oh, wow. I've never used one of those as yet,
Yeah.
so
The
thank you.
Paritas or the Picos, and for some people, they work out great. My father-in-law had one after his knee surgery, and his knee swelled up something fierce because he had a lot of comorbidities, he has heart failure, and then the silicone and it just sort of started like stretching and tearing a little bit at his skin because he got so edematous, so I had to peel that back, and I'm just not a fan.
Uh-huh.
No, no.
And what's underrated? What do you think is the most underrated?
I don't know, I'd slap a back on everything if I could. Not the right answer, but I really, and I know that sort of like jive doesn't jive with me because I never look at my incisions, but I just think they do such a wonderful job of contracting a wound and giving you good granulation tissue.
Mhm,
I just really like them. I can't, again, speak about them too much outside the hospital use.
mhm,
I have sent patients home with them, but the office that I work with usually deals with the outpatients, but in the inpatient
mhm,
setting, boy, I just like to go in there and see a good raisin
mhm.
and see just a little bit of serous sanguinis output in that container and feel pretty good about that.
That's beautiful. That's I totally feel you. I get it,
Mhm.
I can understand that, but I've been without a wound vac for over a year and a half. I keep on telling people that. It's just like I feel like I was in, the Wild Wild West when I was,
Yeah.
in my home country.
Yes, absolutely. And with feet, like they're not giant wounds that, so they might not be appropriate for a vac, but oh boy, do I love a vac.
What do you think is the most overlooked sign that a foot could be heading towards osteomyelitis?
Oh man. Like, I mean, anytime I see slough, I
Oh.
worry what's under that slough and I want to get under that slough. And in my institution, again, we tend to rely on imaging to look for osteomyelitis. So,
Mhm,
they teach you the board answer is probes to bone. I do that with every wound I encounter, particularly with feet. But in my institution, we do tend to rely on imaging for us diagnosing osteomyelitis.
so what do you think is more dangerous in limb salvage? Is it delayed referral or delayed imaging?
Mm. Probably delayed referral.
Yeah.
Yeah, I honestly do. And of course, that is resource dependent. That is really dependent upon where you live and
Mhm.
whether or not you are in a healthcare desert or in a austere environment or,
Mhm.
in another country. So it's yeah, it's kind of difficult to say really, like, where are
Mhm.
you and do you have access to that kind of referral that you need? Yeah.
What do you believe is the most important member of the surgical team, excluding the surgeon, because we already know he's like the head?
Oh, wow. Like, everybody's important, that's the thing. Everybody's
No,
like
I
from
totally agree with you.
right, from, like, the nutritionist who helps us, increase our protein stores to the infectious disease doctor that kindly manages our antibiotics and how long they're going to be and, engages the case manager who says how long the antibiotics need to be and how they're going to be paid for and the folks that work over in hyperbaric for us and the PTs that ambulate our patient and know our protocols all the way to the nurses that know how to do flak checks Q1 hour, Q2 hour, know how to listen to we use implantable Dopplers for our free flaps sometimes and so they listen to that Doppler sound and then they'll actually use the pencil Doppler and they know how to tell when
Mhm.
there's a problem with the flap when because most free flaps fail because of venous congestion.
Mhm.
So they know how to look for that and they know what to look for and they know that they can pick up the phone and call us to, even our respiratory therapists that manage our head and neck cases that have tracheostomies in place. We look towards them to be able to let us know when they've done their, breathing trials, when these patients, when these patients have, okay, their RSBI is, below 50, so they're a candidate for extubation. And that tells us we can move the patient along. So, and of course, to our walk nurses, let me not forget them because they're a big, important part of this as well. They manage a lot of our wounds and our wound vacs, and they call us and tell us, hey, the patient's ready for reconstruction, the wound looks really clean, or there's some issue with this back placement. I'd like to try, a contact layer, or, there's an issue with the peri wound and we're going to, place a drape down over that part. All of these patients are important. I wish I could say there was just one, but everybody's pretty important and everybody does their part.
You're completely correct. Thank you.
Mhm, mhm.
So, this is the last question. What's
Okay.
one lab value that you always want to know before deciding your next steps when it comes to like limb salvage or a flap?
Oh, wow. Probably the A1C.
Yeah. Mhm.
I mean, I need that number really. Our docs do still, look at nutrition labs, but if I have a patient, if I'm referred a patient that has an A1C of 11, that's gonna be a very different patient than the patient that I present to my doc that has an A1C of, 7.2. That's gonna be a very different presentation. So, yeah, I look at that A1C.
And, this is I know I said it was the last, I lied. So this is quick last what's
Heck,
the m this is the last this is the last one. What's the most satisfying part of limb preservation for
um,
you?
no, seeing patients smile,
Mhm.
when, after they've had a surgery and that, they're sort of at the end of their journey and they're pleased with their outcome. So patient smile just makes you smile, You can't help it.
You're so sweet, Stephanie. Like,
Mm.
I would feel so safe around you. Like
It's so funny. I mean, it may not be a pie in the sky, but I like to think that things do work themselves out. And if they don't, then I'm there and, I'm there to hold the patient's hand. And that's just how my practice is informed. So,
Yeah.
yeah.
Okay. Thank you, Stephanie. So this concludes our amazing episode with Diabetic Foot Files LIMBWatch edition. And we thank our amazing guest, Stephanie Stellini Turner,
Oh,
physician
thank you,
associate,
Gabby.
who is who brought amazing expertise and insight to the realities of surgical and limb preservation care. And conversations like this moves us better towards better protocols, better awareness, and ultimately better patients outcomes. And until next time, stay dig early. We can save early.